training to get the buprenorphine waiver. So again, just a lot of different things that we do. Okay, so the topic today is mental health comorbidity and substance use disorders, and that obviously could be many hours. So this is really going to be a kind of just an overview, and we also have a fair number of non-prescribers. So we'll talk some about medications, but it'll be more kind of broad, general issues around that. So just a little bit, because you're going to hear a lot of different terms to describe this. The most common has been dual diagnosis, which is a good idea, but the majority of people with comorbidity have more than two issues going on with substances and mental health. But you have mentally ill, chemically abusing, mentally ill, substance abusing, chemically dependent. A lot of these are actually, we're now really trying to get away from the labeling the patients to begin with, and trying to do the patient first. So really trying to get away from using these labeling. So a lot more now we're just talking about just general comorbidity. I don't know how many of the people on are more from primary care and addiction side. So just to make sure everyone kind of recognizes what's new with the DSM-5, because a lot of changes were made. Just here some of the different classifications. I'll just highlight, it used to be mood disorders kind of included depression and bipolar. They're separate. Obsessive-compulsive disorder used to be in with anxiety disorders. DSM-5 separated out. Other dissociative, a lot of the kind of a little bit less common things here. Substance-related and addictive disorders, we'll talk a little bit more about that. And then, some of the other things. So again, as we talk about some of the diagnoses, much of the research was done back at, with DSM-3 and 4. And so some of the terminology, some of the diagnostic classifications really don't apply from DSM-5 to a lot of what the research is based on. Just to, again, if there are people here that are used to DSM-4, just to make sure, recognizing with DSM-5 that in order to include pathological gambling or gambling disorder, they changed the overall kind of the grouping that substance-related disorders goes into to include other addictive disorders, which is gambling disorder. And then we did away with substance abuse, substance dependence, and made it just one continuous substance use disorder. It's a little bit confusing because ICD-10 still uses the abuse and dependence, and we use that for billing here in the U.S. ICD-11, which is going to be out soon, though I don't know when we'll use it in the U.S., that's going to be more aligned with the DSM-5 as far as the substance use disorders. Part of, again, when we're talking about comorbidities, are important to be aware of, but just to mention that at least in the DSM-5, these things were not recognized as other addictive disorders. So a lot of people talk about sex addiction, eating addiction, these kind of things. Some of them fall under other diagnoses in DSM, but again, it's really only gambling disorder that was also included with addictions. But important to be looking at these. Internet gaming, though not in DSM-5 as a full diagnosis, it's actually going to be in the ICD-11 when that comes out as a full diagnosis. So as we start to talk about the psychiatric diagnoses and psychiatric symptoms with substance use, it's really important to distinguish that, this is just, the numbers don't really matter, but if you look at people who have psychiatric symptoms in the general public and then actual psychiatric illness versus people who also use substances, so almost by definition, this white box here, you're going to have a lot of people with psychiatric symptoms because most things that people abuse, part of why they're using it is because they work, on our emotions, our perceptions, energy, psychiatric symptom kinds of things. So many people, when they're using substances, will have the symptoms, and we'll talk about the actual comorbidity. A lot of those people will have a full psychiatric illness, but a number of those people will not. They'll have the symptoms when they're intoxicated, when they're in withdrawal, but otherwise don't have the psychiatric illness. But still, it's much more than the general public. So just to think about that, this is kind of what that's talking about. There's obviously a lot of overlap because of those symptoms, but again, there are a lot of people that use substances that don't have a psychiatric disorder and vice versa. So just to think about, how we go about trying to tease all this out. So it's important to remember with substance use disorders, it's a very multifactorial thing. You need the biology, which people inherit, like genetic predispositions to addiction. The environment is important, how you're raised, the exposure to drugs, those kind of things. And then the actual substance. Obviously, you don't develop a substance use disorder if you're never exposed to the substance. So you really kind of need those three things to develop a substance use disorder. Similarly, with psychiatric disorders, we don't have things that are inherited kind of the way you inherit, eye color, things, in a simple way. Like substance use disorders, you inherit some of a biological predisposition, but very strong social cultural influences, as well as other kinds of stressors, environmental stressors, things like that. So again, we have substance use disorders, psychiatric disorders. We don't have blood tests for them. We don't have good other kinds of testing yet that we can kind of look for these things. So you have these very multifactorial disorders, and as you start seeing, with our patients, as you start looking, it's all combined. We have a system that, in the past has separated the funding to pay for addiction versus mental health. A lot of the research is done separately. A lot of the treatment we'll talk about is separate. So even our treatment system makes it often hard to kind of sort through this. And then you throw in patients with pain, which a lot of our patients have as well. Another thing, that there's not a blood test for it or a good kind of imaging test. It's a thing that's very influenced by your biology, social cultural issues, and the painful stimulus. So we just start to see, as we add on more and more of these multifactorial things, this is what our patients look like. So it's nice. Sometimes we have very clear where you can distinguish the substance use disorder, the mental health issues, the pain, the other medical conditions that are going on. But with a lot of our patients, it's really hard to tease it out. Also important just to remind everyone that there's a big difference between just being physically dependent and developing an addiction. Certainly, many people with opioids, with benzodiazepines, will develop physical dependence if they take them chronically, but many of them will not develop addiction or substance use disorder. So as we talk about comorbidity, it kind of helps to divide it into three main buckets. So one is a common factor model, and again, we could spend hours just on this, but this involves when you inherit the predisposition genetically, you're inheriting something that makes you more likely to have both substance use disorder and some other mental health issue. There's a lot of research in the kind of sensation-seeking impulsivity types of disorders, so antisocial personality, conduct disorder, but even attention deficit hyperactivity disorder. A lot of overlap in the brain circuitry involved with seeking sensation, being impulsive, and substance use disorder. Then there are other models that look at a primary psychiatric disorder model, and people typically would call this the self-medication hypothesis. So this is the feeling that somebody develops a substance use disorder because they're trying to use substances to deal with an underlying psychiatric condition. they're, looking at supersensitivity, reward deficiencies, people looking at this as far as kind of when you are predisposed to this, you have problems with your dopamine system that other substances might help. So again, it's another model of looking at this. And then the third one is a primary substance use disorder model. So this is where the idea that using substances will cause someone to have a psychiatric disorder. So there are people that have never had panic attacks that use cocaine, say, will have a panic attack, and then even if they stop using cocaine, they can still continue to have panic attacks and panic disorder. Other, using cannabis, a lot of literature on whether that can actually cause psychosis in some people. So again, these three kind of ways of looking at the comorbidity, and I think what's important, because a lot of times the literature will present one or another of these as being what causes comorbidity, and I think what the reality is that with different patients, it's more or less of one of these that's contributing to the comorbidity for them. Hopefully down the road, we're going to develop better, blood tests, genetic testing, imaging, and we're going to be able to better sort out the different people that fall in these different categories. But I think for now, it's just useful to think about the categories, but to also think that the categories don't all apply to a given patient, and some fall more or less in one or the other. So just kind of going from there, this is just looking at, someone does have a primary psychiatric disorder. They start, say, drinking to help with their anxiety, leads to a substance use disorder. Over time, the disorders can progress on their own, but more often what's going to happen is the symptoms become intertwined. So even if it does seem to have been a kind of self-medication initially, over time, as the symptoms and the various consequences of the substance use, the symptoms of the psychiatric disorder, as they continue to progress together, they often become intertwined. And then in the end, it doesn't matter so much if you just treat the psychiatric disorder. It doesn't necessarily mean that the substance use disorder is all of a sudden going to get better because you treated that primary psychiatric disorder. So just to keep in mind the relationship of psychiatric symptoms to substance use, so not necessarily substance use disorder, but so again, a lot of it we already talked about, that they happen by some unknown connection. We talked about it causing a psychiatric condition. Often substance use can increase the severity of symptoms, so make hallucinations worse, things like that. Psychiatric disorder causing an increase in the substance use. So somebody who's bipolar, when they're in a manic episode, will often be using more substances. Substance abuse resulting from the treatment of a psychiatric condition. So we'll sometimes see this with people misusing, say, a stimulant prescribed for ADHD. We see people with schizophrenia sometimes misusing their cogentin that's prescribed for the side effects of the antipsychotic. So sometimes you'll see that. Both disorders caused by another condition. You can see this with different medical and neurological things. And a big one to keep in mind is that a lot of intoxication and withdrawal syndromes can look like other psychiatric disorders. We'll talk more about specifically. The impact of comorbidity on the patient, as you would expect to have two bad diseases, is that it's mostly bad. So they're going to have more psychiatric symptoms, more symptoms of their substance use, less good compliance with both psychiatric medications and substance use medications, more psychiatric hospitalizations, increased disruptive behavior, decreased social functioning, and actually it often leads to more medical problems and medical hospitalizations as well. So to think about how to try and tease out what are these independent or not, here's some ways you can try and do it. They're a lot easier said than done. But so observation of symptoms during a period of abstinence. used to be a lot easier when people would get admitted to a psych unit and be there for weeks and months at a time. That often doesn't happen now, especially if the person uses substances. But trying to get them, either seeing them when they are absent or trying to get them to think back and just say, back in, 6 years ago when you said you had stopped using, did you still have those hallucinations? Did you still have that depressed mood? And some patients can really kind of tell you about that. Family history of psychiatric disorder is important. So if somebody has a family history of bipolar disorder, just statistically, it's more likely that the patient also has bipolar disorder. So that's great if the patient really knows and, that's clear. The problem is that, Uncle so-and-so that they thought had always been told had bipolar disorder, he also used cocaine. So again, it's nice if you can get that clear history, but that's not often there. And then the clear onset of the psychiatric symptoms prior to significant substance use. Again, sometimes it's very clear that the person had little substance use, had a major trauma, say, or something like that, and began using substances. So it really does seem like they're independent. But again, with a lot of people, they're experimenting with substances in their teens, and they're having depressive or other psychiatric symptoms in their teens. So again, all these are nice if you can get that kind of history, but with a lot of patients, it's not going to be that clear. So now we're just going to spend a little time about talking about epidemiology. And I mean, the main thing is that there's just huge comorbidity. So I'll talk about different studies and their numbers, but the bottom line is we know that it's grossly underestimated, especially looking at treatment settings. A lot of people aren't reporting or aren't getting into treatment. So just a little, we're not going to go through all these, but we're going to post this after, so you'll be able to look at it. But just to be aware, these are some of the big studies that we'll talk about that have tried to look at comorbidity over the years. And again, I'm going to just talk about some of them specifically. So the first one that was on there is called the Epidemiologic Catchment Area Study, and it was done in the 80s, so back with the DSM-3. But back then, they found that 45% of people with alcohol use disorder and 72% with a drug use disorder had at least one other co-occurring psychiatric disorder. And this was in that study, the breakdown, so schizophrenia. And this doesn't include tobacco, which is, in many studies, 80, 90+% of people with schizophrenia, but not including that, still 50% have another substance use disorder. About 20% with major depression, over 50% with bipolar, and then most of the anxiety disorders, about a little over a third, had another comorbid disorder. PTSD, depending on how it was looked at, up to 50%, ADHD about a quarter, and I just included here in a social personality disorder, which they looked at. I just want to, really highlight this, that it's important because once people develop a substance use disorder, a lot of times they're doing antisocial behaviors. And it's easy to label somebody with antisocial personality disorder, but really just to encourage people to avoid that, because a lot of patients, as they get better with their substance use disorder, those antisocial behaviors go away. And so they don't have the disorder, they had antisocial behaviors related to their addiction. But a lot of times we'll see this in somebody's chart, and the problem is once that's in there, it's never coming out, and it affects, when somebody looks at that chart before they see the patient, it affects how you think of the patient. So this is another one of the big studies that try to look at comorbidity, the NESARC. So this was done in the 2000s, so at DSM-4. Tons of patients were interviewed, and not very different from the last one. So most of the, any mood disorder, 20%. So the odds ratio means it's 2, almost 3 times as likely to have a substance use issue if you have a mood disorder. And similarly with the anxiety disorders, you see about 20 or 17%. So with all of them, they were 1.9, so it's almost twice as likely. So again, for most of these, you're at least twice as likely to have a substance use problem if you have an anxiety disorder. Just looking at the NESARC a little bit more. All respondents, any mood disorder, any anxiety disorders. So again, significantly more compared to the general public without substance use disorder. Just going to skip through a few of these. So again, there are a number of studies over the years that have looked at this, kind of bigger surveys, but I think what's more useful now is to look at the National Survey on Drug Use and Health, it used to be called. This is the annual survey that's done that tries to get more kind of real time what's going on. So in 2017, so this was the number of people with any mental illness, serious mental illness, which the way they classified that was anyone who said that their mental illness had significant effects on their life. Looking at it by adults here, over 18, so you see basically 46 million people reported that they've had some sort of mental illness. And you see that's pretty stable over time, except for increases in the 18 to 25 and 26 to 49, which we're actually seeing increases. And there are other studies showing this as well. This is looking at youth. So this survey does 12 to 17-year-olds. So 3.2 million youth reported having a major depressive episode in 2017. And again, those numbers we're seeing going up with teens as well. This is looking at the adults' major depressive episodes, 17 million. Again, going up mostly in this 18 to 25 young adult. So now as we start to look at the comorbidity, so you see here past year substance use disorder and major depressive episode among youth. So you see 2.9 million, and over here 1 million with the substance use disorder. So, about a third of them with the overlap of the substance use and the major depression. And then as we look at adults, so remember they have much higher numbers, but 38 million have 18 million with a substance use disorder. So again, about 8 million of them with the overlap of substance use and mental illness. Just to break down by ages, again, a lot in the young adults and more but less in middle-aged. Just a little bit, we'll talk more about suicidal thoughts, but looking at just attempts and plans in the past year. But again, 10.6 million adults with a serious thoughts of committing suicide. So, huge issue with substance use disorders. Just going to skip over these. So this is looking at receipt of mental health services and specialty substance use treatment in the past year among adults. So you see here, about half had no treatment, 38% with mental health only, and then here with 4% with substance use only, and only about 8% with both together. So again, something that we really need to be improving how we do that. So now we're going to move into the treatment of comorbidity. And what I think is really important to stress is how, our kind of traditional view of treating substance use disorders in the U.S., where it's kind of like all or nothing. So you're either using or you're not. And I think it's something we really need to look the way we look at other chronic, the way we look at diabetes or other chronic medical conditions is really much more along a continuum where the person's having more or less consequences of their use. So it's not necessarily absolute use, but it's more looking at the consequences that somebody's having of their use. And obviously that's important with comorbidity because we already mentioned if somebody has a bad psychiatric disorder and substance use disorder, they're going to struggle more with adherence to medications and those kinds of things. So it's really important to look more on the continuum rather than to look at that kind of absolute abstinence from all substances. So just some kind of general concepts around treatment. So we already mentioned that in general, these have developed in parallel in the U.S. Very different funding, very different treatment systems. Psychosocial treatments are extremely important in both, which I'm hoping everyone in this audience already knows, but I think it's something that we really have to remember. Pharmacologic interventions, they're more limited. We'll talk about benzodiazepine stimulants, those kinds of things, but things that you would use in a different way with somebody with no history of substance use disorder, it's much more limited when somebody does have that history. And I just put a little bit in here about some of the potential advantages of comorbidity. So, it kind of makes sense, but if you have 2 or more bad disorders, it makes it more likely that you may end up getting identified by someone and may end up getting treatment. And there are some studies that certainly with people with comorbid major depression may be more likely to seek help those with addiction alone. And we mentioned some of the disadvantages. So obviously, somebody has a severe psychotic disorder that can really make some of the psychoeducation you would otherwise be doing much less useful. Big one is people with social anxiety, panic disorder, things like that, may have a really hard time in groups. So make it hard for them to engage in the traditional kind of group therapy that a lot of programs rely on, but also make it hard for them to even really take advantage of 12-step groups. So something to really keep in mind, especially with social anxiety. Depression leads to a lot more morbidity and a lot more relapse with both the substances, but also with the mood symptoms. And then, what we call cluster B personality, so antisocial, borderline, those kind of things as well can make it harder for somebody to engage in some of the traditional treatment, like in traditional outpatient treatment programs. So people look at, this is one model that some people may have seen before, of thinking about the severity of comorbidity and just having these 4 quadrants. So somebody who has less severe both, somebody in quadrant 4 who has very severe both, and then here where you have more severe substance use and less severe mental health and vice versa. So sometimes it can kind of help to put people in these 4 quadrants as you're trying to think of the best setting or the best type of treatment to use. It's more just kind of general principles. So it often helps to think of treatment in stages, so especially with substances, that somebody may need to be tapered or detoxified or just otherwise stabilized before you can kind of think about more maintenance treatment as far as both the mental health and the substance use. Big concept here of treating both disorders together that we'll talk more about. Avoiding overtreatment. So there's literature both in mental health and the substance use disorder that it's really important to match people to the level and amount of treatment, not just assume everyone needs the highest level of treatment and should be stepped down. And there's some good studies showing that if you don't really match people, they don't do as well. So some people don't need to start with as intensive treatment, and if you try to do that, they'll actually stop coming because that isn't really what they need. Using medications that may treat symptoms of both disorders, we'll talk more about in the different disorders. Thinking about the least abusable medications first, which again is common sense, but doesn't always happen. And monitoring more for toxicity, misuse, and diversion of the medications. So these are kind of 3 ways to think about treatment, and we'll talk about the third one here, which is kind of the best but not often done. But typically what many patients get is a parallel model. So they go to one clinic for their substance use disorder and a different clinic for their mental health disorders. That's, again, for various reasons why much of the treatment in the U.S. has been done that way. There's also the serial or sequential model. So we see this so the VA used to do this, they don't now, but in order to get into the PTSD program, you had to be abstinent from substances. So you had to go to the substance use disorder treatment first, then you could get in the PTSD program. But a lot of people really struggled if they kept drinking because of the flashbacks. If they weren't having the PTSD also treated at the same time, they really struggled. So again, this sequential model, in places have used it, but is really difficult if you're not addressing the issues. So here, the third model is really the best, where it's integrated, where somebody goes to one program and they're getting all their care from staff that are trained both in the substance use disorders and the other mental health disorders. So it's easy to say that this is what should be done, but obviously requires the staff to be better trained and more versatile. People may have heard these terms. When you're talking about co-occurring treatment, places that are co-occurring capable versus co-occurring enhanced, just really speaks to kind of the level of treatment and the level of training of the staff, what they can, what they're able to offer someone with what level of mental health and addiction. Also, just as we're talking about treatment, if people aren't aware, there's Dual Recovery Anonymous, so a separate 12-step mutual help group that's set up for people with co-occurring. So I encourage you to go look. I just did a screenshot of some of it. There aren't tons of these meetings, but there are some in the area, so it can be useful. Okay. So now we're going to move on and talk about some of the different syndromes and the different categories of disorders and specific things to do around treatment. But first, I've already alluded to this, but extremely important, if people aren't already aware, huge co-occurrence of suicidality and substance use disorders. So again, just some different statistics here, but just huge co-occurring, 50 to 70% of completed suicide with substance use. Suicide in those with alcohol use disorder in one study, maybe 30 times that the general public. So again, I don't think anyone listening to this would be surprised, but so important that we, if you have somebody with both substance use and mental health, that you're screening for suicide and continually monitoring. Okay, so as we start, we'll talk first about psychotic disorders. And I already mentioned that, during intoxication, a lot of different drugs can make people psychotic. Less so, and again, it's a big controversy how much marijuana can do this alone. Also, especially with withdrawal from alcohol and sedative hypnotics, when people are delirious, they can also be psychotic. So just a little bit about treating people with schizophrenia with substance use disorder. People will sometimes be using their other substances to help with some of the negative symptoms, especially like cocaine. Some people with schizophrenia may feel it's helping them with some of the negative symptoms of the disease. Some are also using it to offset some of the positive symptoms. Some feel that marijuana actually helps them deal with their hallucinations. Some improving thought process, so stimulants, can help people with thought process, and some people with schizophrenia feel that it helps them as well. And again, some people may be trying to use things to help offset some of the side effects of their medications. So just some real broad things to think about in treating schizophrenia. There's some evidence that using atypical antipsychotics may be more helpful with people with comorbidity, may help a little bit more with the negative symptoms, may have less side effects than the older typical antipsychotics. Some evidence that adding an antidepressant may help with some of the negative symptoms as well. Just some things to highlight: being careful with disulfiram or antabuse for alcohol, because that actually not only affects alcohol metabolism, but it also affects the metabolism of dopamine, which is related to hallucinations. So people with schizophrenia can also often get worse with antabuse. Naltrexone, and I didn't add in here, camprosate, have not really been studied. smoking cessation. There are a few studies looking at that with schizophrenia because it's such a high comorbidity. But it gets very complicated. We don't have time to go into now, but the issues of the effects of nicotine on the metabolism of the different antipsychotics is important. So again, it's important to be addressing, but it's important also to realize that it gets very complicated. And then I just added this here with methadone because most of the antipsychotic medications can have an effect on QT, the thing on EKG that we look at that puts somebody at risk for having arrhythmia. So it's really important, especially with the antipsychotics, for somebody on methadone to be monitoring for that. Looking now at depressive symptoms, so a huge overlap with substance use disorders, and there's some studies where almost everyone coming into substance use treatment has depressive symptoms, which kind of makes sense. You're going to have some of that as, neurochemistry, and some of it is often people are coming into treatment because their life is falling apart. So they have other, situational reasons to be depressed. But with a lot of people, as they're getting better with their substances, those symptoms will get better. Again, we don't have time to go into a lot of detail about the treatment, but there are some studies that SSRIs, fluoxetine or Prozac has been looked at the most, but may be helpful for people who also have concurrent alcohol use disorder. The tricyclics, like the old medicines like Elavil, some evidence that they may help, but it's also important to remember the added cardiotoxicity that you might see, especially with things like cocaine that are also cardiotoxic. The MAO inhibitors might be useful, but again, with all the dietary restrictions and things, and when somebody uses substances, there can be real issues of them, not sticking to the diet, issues with stimulants and MAOs. So again, they're not used a lot anyways, but probably even less so with comorbidity. And I put down here at the very bottom buprenorphine with question marks. So there's more and more evidence coming out that buprenorphine, in addition to working at the opiate receptors and helping with opioid use disorder, works at the kappa opioid receptors as well, which seem to be involved in depression. So certainly, anecdotally, I've seen a lot of patients on buprenorphine feel that their mood is better when in the past on other treatments they didn't notice that. And there are some studies now being done looking at buprenorphine specifically for depression. But I think it's really something, if you have a patient who you're starting on buprenorphine, they say they have a history of depression, they're not so depressed now, I'll often say, well, let's see, buprenorphine does seem to help people with depression as well, so let's get you on this and see how you do. And a number of people do fine with that. So again, more to come with that as some of the studies come out. Looking at manic symptoms, again, you can see a lot with cocaine, other stimulants, PCP. With substance use disorders, you tend to have more mixed episodes and more rapid cycling than you see with people without substance use disorder. Not a ton of controlled studies with comorbid bipolar and substance use disorder. Some studies showing that actually maybe a poor response to lithium if somebody has both. It's also important to remember that lithium can be very toxic. So with, again, somebody who's drinking a lot and they forget and accidentally double or triple their lithium dose, you can get into trouble pretty quickly that way. The other thing is because of the higher rates of suicide, lithium can be used in suicide. On the other hand, there's some evidence that lithium as a treatment actually may help with suicidality better than some of the other medicines for bipolar. Some evidence that patients with bipolar may respond better to some of the anticonvulsants because they seem to help better with mixed and rapid cycling. Some studies with valproate that show promise. So again, there just haven't been a lot of well-controlled studies looking at patients with the dual disorder. And looking at anxiety symptoms, hugely problematic with alcohol, so there's hypnotic opiate withdrawal, and then with a lot of different intoxications like stimulants. So just to, this is everyone's biggest question in treating anxiety in someone with a substance use disorder, and I think people tend to weigh in one way or the other. There just aren't a lot of data to support whether benzos even, it's sort of like the issues with opioids for chronic pain. It's things that have been done for a long time without a lot of data. So it's, again, something to keep in mind, and we'll talk some about the different disorders. But just to look at different medications that are used to treat anxiety, and especially with people with substance disorders, so Buspar, Buspirone, the SSRIs, hydroxyzine, people know as Vistaril or Atarax, can help some people with anxiety. Propranolol is used more for kind of situational, like public speaking, those kind of anxiety situations. Atypical antipsychotics, so there are people using things like quetiapine or Seroquel more for anxiety. Gabapentin or Neurontin, a lot of use of that as well to treat anxiety. And then I put here at the bottom benzodiazepines. Again, we'll talk more about that, that they're not an absolute indication, but you certainly need to be careful. And then, it's important for all mental health issues, but especially for anxiety, psychotherapy, CBT, things like that can really be helpful for the various anxiety disorders. So just looking at panic, again, about a third of people with the comorbidity. And, as we're looking, a lot of people use benzodiazepines for panic. And I'm not saying you would never do that with someone with a substance use disorder, but you really want to be careful. There's debate over whether, say, someone is only a stimulant user, are they going to misuse a sedative like a benzodiazepine? Some people think if someone abuses one thing, they'll abuse anything, but there are definitely patients that only abuse certain types of substances and can use other substances safely. So you certainly want to be trying the more typical treatments anyways, SSRIs. Again, with panic, CBT can be very helpful, so really stressing that. Generalized anxiety, often hard to diagnose because you need that 6 months of non-substance use to get the diagnosis, but certainly a lot of comorbidity. And that can be really tricky because, again, a lot of people, when they're coming in to see you, they'll already have had people prescribing them a benzodiazepine, and so that's what they feel works. So really trying other things. Buspirone will work with some people. SSRIs are very helpful, so you definitely want to try that. As I mentioned before, not an FDA indication, but a lot of people using gabapentin also to treat generalized anxiety. Social anxiety, we already mentioned, a huge comorbidity, especially with alcohol. People find that it kind of disinhibits them and makes them, more able to interact with other people. But not a lot of studies with this. But again, I think it's really important to keep in mind that it really affects the common treatments that we use. And some people may really struggle with group therapy, with 12 steps. So really trying to individualize care and do more individual therapy with someone if social anxiety is really impeding their ability to engage in the group. Again, like all the anxiety disorders, SSRIs really work well for social anxiety. But again, a lot of people may have already been on benzodiazepines, so that's always a real struggle. Mentioned before, propranolol can be really helpful, kind of situational social anxiety, like public speaking. Obsessive-compulsive disorder is interesting. It's one of the only disorders where it's not clear that there is a higher rate of comorbidity with OCD. PTSD, and this is really expanded because each version of DSM, we've kind of expanded the criteria for PTSD. So now, many patients, when they come into treatment for substance use disorder, meet current criteria for PTSD. So really important just to be focusing. You kind of have to gear that we don't have very specific treatments for PTSD as a whole syndrome, so you're really kind of more focusing treatment on the more mood symptoms versus the more flashbacks and more, perceptual things versus the more hypervigilance and anxiety things. So, but, sertraline Zoloft is one of the medications approved for it and does seem to help. Nifazodone is a medication that was helpful. It's, it was pulled from the market. It's still around, but not used a lot. But you see more use of atypical antipsychotics and different mood stabilizers, which again may help with both the PTSD symptoms as well as the substance use. Eating disorders, common both in the more bulimia and more anorexia. Bulimia is going to be much more kind of what other people use, alcohol, benzos. Anorexia, more stimulants because of the weight loss, but other things that people actually will develop use disorders to, even diuretics and laxative, things like that. So some evidence that fluoxetine may be helpful for comorbidity with eating disorder and substance use disorder, but remembering to look for it. Big one is ADHD, and again, we could spend a lot of time on this, but the bottom line is a lot of people worry that, especially for children, putting them on a stimulant is going to increase the risk of them developing a substance use disorder. And there have been a number of studies now that show that that's not the case. And actually, if you don't treat somebody's ADHD in childhood, they're more likely to go on to develop a substance use disorder as an adult. So it is controversial, and you'll see different people weigh in differently, but a number of studies showing that it really is good to treat it as a child, obviously being careful, but it does lower the risk that the person is going to develop a substance use disorder as an adult. Some people actually, there are different stimulants that are used. Some people actually respond to bupropion or Wellbutrin for ADHD, as well as atomoxetine, which can help. So again, you want to often try the less abusable things, but again, there are some people that use opioids, abuse alcohol, and are able to use stimulants in a responsible way. So again, you just really have to individualize treatment and really monitor someone carefully. And then the last thing I just put in here with dissociative disorders, a lot of alcohol and sedative misuse with those. Again, if you're seeing people with dissociative disorders, really important to be aware of that. And again, that's a complicated disorder to treat, but to be aware there's often a lot of substance use disorders with that as well. So again, that was real quick, get a real quick overview. Maybe down the road we can just pick one of those and do a whole webinar on that, but I threw in this, and I already mentioned this before. Really, again, there's going to be a lot of personality disorders in substance use disorders and substance use disorders treatment, but really important to distinguish the acts from the disorder and not be labeling people just based on the acts. Well, if people think of questions down the road, they can certainly email. So the email, you can go through our website. You can actually get to the email with questions. You can actually call in. Again, we have the warm line, so you're able to call with questions, certainly for resources as well as questions about a specific patient. Feel free to call us at our line here.